Good. Well, welcome everyone, and thanks very much for joining us today. So I'm going to talk about the Betalactams. They're an enormously big group of antibiotics, but more than half the prescriptions that are written up every day around the world are Betalactams still. They're the first and most recent antibiotics. And I wanted to give a clinical overview of this. It's clearly not possible to cover everything that you need to know possibly in 1 hour, but this should be a good overview. I hope that people can take away some improved knowledge about Betalactams. I'll start with a bit that you don't have to remember, and that's what the hell a Beta-lactam is. So I had to brush up on my chemistry, but I just wanted you all to be aware of it because in fact, we will use this a few times throughout this talk. This is a carbonyl group. No one in this group, I don't think, will know what a carbonyl group is. If you do, you're well ahead of me. But a carbonyl group is when you see this carbon atom double bonded here, the two lines to an oxygen atom. So if that's a carbonyl group, then, and I promise we're working towards the beta-lactams, this is an amide. An amide's when you've got a carbonyl group and that carbon is linked to this nitrogen. It's bonded to the nitrogen. So when you start seeing carbon, double bonded oxygen, linked to a nitrogen, that's an amide group. But what if those R's are just the extra side chains, for example? But what if you linked them in a ring? So what if you made a cyclic amide? And any cyclic amide is called helpfully a lactam. And you can see some of the examples there below. Give you some sense, this is a 4-carbon ring here. This is a 5-carbon ring, 6-carbon ring, 7-carbon ring. All of these are lactams. So remember, this is the carbonyl group. This is the amide together when it's binded to the nitrogen. And when it makes a loop, when it makes a ring, then that's a lactam. So we're getting there. We're starting to understand lactams. What about a beta-lactam? Well, you can see the names here. That's a beta-lactam on the left. That's a gamma, a delta, for example, epsilon lactam. And really what it means is that this carbon, not the carbon that's part of the carbonyl group, but the next one across is always regarded as alpha, and the next one is beta. So you can see this is an alpha and a beta. So if you can go alpha, beta, gamma, then it's a gamma lactam. And for example, we don't really have much in the way of antibiotics apart from beta lactams, but now you get the sort of sense. And I'm going to show the structure a couple of times later, not that you have to remember it, but just so that you've got some better knowledge of what we mean when we talk about this when we're going forward. And this sort of thing, this almost the square, so that with 3 extra carbons on here. So it's 1 carbon, 2 carbons, 3 carbons, mixed nitrogen. So double bond oxygen, nitrogen over there, beta-lactam. That's the key structure to look out for as we go. You don't have to remember a single thing of that, but that's a bit interesting at least. Second thing to understand is that fungi really hate bacteria. They hate bacteria almost as much as infectious diseases doctors hate bacteria. And they know more like bacteria than you or I do. And so unfortunately, they can't develop their own antibiotics by planning, but they can evolve them. And so if you really want to know how to kill bacteria, one very good place to look, and this has been done historically over the decades, right from the 20s onwards, is to look at what the fungi are doing to kill the bacteria, because they often elaborate compounds which are very good at killing bacteria. After all, this is what they've evolved to do, because often they compete for resources, for example. So this is what happened in 1928. This is a picture of the exact culture dish actually that happened. A gentleman, a very famous gentleman who you will recognize over there, Alexander Fleming, decided he was actually a bacteriologist, and he was interested in staph, and in particular he was looking at determinants of staph colony morphology. So he had plated out a bunch of plates with staph. He went away on holiday, he came back, and then what he found, because these were left a little bit longer than average because he was away on holiday, was that they had contaminated themselves, some of the plates, with mold. This is the mold at the top here, and he identified the mold correctly as Penicillin. That's the name it already had for that mold. But what he noticed brilliantly is that the staph colonies around the mold weren't growing. They were growing very nicely at the bottom. They weren't growing nicely at the top. And of course, you could say, well, you maybe didn't plate it out so that they were at the top, but he was very particular about the way he plated them out. He's a very good bacteriologist. And he knew he'd plated them all the way to the top there. And so the fact that they weren't growing there was interesting. And he immediately thought it must be something to do with what the mold is doing. This is September 1928. This is actually the original picture that he put in his published article from 1929, showing the exact phenomenon over here. And it was actually a stroke of good luck, because there are over 350 species of penicillium, but only 8 of them actually produce a substance which he called penicillin. Had it been any one of the other species which landed on his plate that day, he wouldn't have had this great insight. It's the species that that he named it was, well, it's now Penicillin rubens, but that was the species that he used. And in fact, they found another species a bit later when they're trying to produce a lot more of this, Penicillium chrysogenium, which produces many hundreds of times the amount of penicillin. And that was actually a critical breakthrough, because when you started off with this first, it would never produce the amount of penicillin required to be clinically useful. The first time it was used in a human, though, was many years later. This gentleman was a police officer, and he had the misfortune of getting a bad scratch to the face when he was gardening with his roses. And what happened is, over the weeks following that scratch, he got really bad staph and strep, in fact, infection of the skin and soft tissue around the face. And it was really bad. I mean, you can see they actually had to take out his left eye because it was so badly infected. And despite their best efforts at local therapies, this really wasn't working. So he was he was regarded as on the way out, dying, and therefore it was worth giving a shot at this new thing, this penicillin, that people could try. They didn't have a lot of it, though. They'd only managed, because remember, it was very hard to get enough of this. They only had about 4 grams of it, which is less than a single dose of what we'd use today. They were able to spread it out over 4 days, though, by giving it to him and then collecting it from his urine and giving it to him again. And that's actually important. We'll come to how the beta-lactams are handled by the body in general. But what you need to know is a lot of it comes out unchanged in the urine. So you're able to collect the urine and give it again. And when they gave it to him, he had a wonderful clinical response. But of course, each time they tried to collect from the urine, they got a bit less, and eventually they ran out. And when the drug ran out, he got worse again and died. So it was an unsuccessful treatment, but it clearly worked while it was being given. What they needed and what they understood then from giving it to him is that they needed a lot more. In those days, of course, staph was still susceptible to penicillin. These days, almost none of it is. But in those days, it was. And so he had a very good response to penicillin. This was the first case, kind of proof of concept. And then they tried to scale it up to other people. And this is now, we're talking about in the 30s and 40s. And it turns out it was very, very difficult to get enough of it, because you had to get enough mold producing by fermentation, enough of the penicillin. And this wonderful quote from the Pfizer's executive saying it's as temperamental, the mold, as an opera singer. The yields are low, the isolation of the compound is murder, and the purification process invites disaster. It's very, very difficult, but it did manage to get a lot better. The scientists from Oxford in the UK managed to take this across to America. And between the two of them, especially once World War II broke out, there was a huge drive to get enough production. And it ramped up incredibly quickly. In 1941, United States didn't have enough to treat a single person. At the end of 1942, they had enough for 100 people. But by by September 1943, they had enough to satisfy the demands of the entire Allied armed forces. So this was a massive win. And in fact, historically, battlefield deaths, more people had died of sepsis than actual direct, like from being shot, for example. Most people died of sepsis following that, rather than from the wound itself initially from the bullet. And many multiples, in fact. So this was an enormous factor in keeping people alive in World War II. So that's the history of it. When we talk about beta-lactams, there are really 4 groups that we talk about clinically usefully. You can see them there, and I've put their structures up, the molecular structures, and you can see that beta-lactam ring in all of them. Here it is in penicillin. There, the double bond O, and that almost looking that square is nitrogen as part of them. And you can see it as a monobactam. You can see it in the carbapenem. You can see it in the cephalosporins as well. These are all beta-lactams. There's actually only one monobactam in clinical use at the moment called astrinum, which we'll mention a bit later. But all of those, that's the 4 big groups of beta-lactams. And that accounts for, like I said, more than 50% of all antibiotics that are written up. So how do they work? And this is common to all of them. That beta-lactam ring, it's not just, it gives it the name, it's actually the active part. That beta-lactam ring is critical to its effect or as it goes on. You need to know a little bit about the cell walls to understand it. So gram-positives and gram-negatives, bacteria have a cell membrane like our cells and the human, but they also have an additional layer outside that called the cell wall. And the job of that cell wall is really to provide structural strength to prevent osmosis from destroying the bacteria. So they have to pack in a lot of stuff compared to our cells, because they're sort of one-stop shop in the bacteria. So the osmotic pressure inside a bacterial cell is much higher than a human cell, for example, and they would otherwise just rupture. So they have this strong layer of a cell wall. They've got peptidoglycan in the cell wall. If it's gram-positive, that's pretty much the entire of the cell wall. Gram-negatives have a much smaller layer of peptidoglycan and then another outer membrane. But the point is both gram-positives and gram-negatives have peptidoglycan. So what is peptidoglycan? Well, it's a series of sugars, which the abbreviated sugars can be NAM and NAG, N-A-G-M-A-M. They stand for much longer names, but they really linked together in long chains. So NAM, NAG, NAM, NAG, NAM, NAG, and they go all the way down like a long, long chain. But then to give structural stability, you need to cross-link those chains. So you need to take those long chains, the big circles here, and you need to cross-link them together. And they do that with this oligopeptide. So just a few amino acids just stick out of each of the NAMs. And then what the job of the body, well, the bacteria is to link those cross links together to form this mesh. And you can kind of see here how they're linked. But what links them? Well, it turns out an enzyme links them, a transpeptidase. And that's given the name now by us as penicillin binding protein, which gives you an idea of how this works. But of course, the enzymes are not designed to bind penicillin. They're designed to cross-link these two arms of the oligopeptide together so that they make this firm structure of the cell wall, this peptidoglycan. And that's how they normally do. This is the enzyme. It comes in and it catalyzes the conversion of these bonds, and that gives it strength. So what does penicillin do? And all the penicillins and all the beta-lactams do is that they bind to this enzyme. So they actually basically block it working. So the penicillin will come, they'll bind to the penicillin binding protein, and they link together. When it links together, the penicillin binding protein can't anymore catalyze the conversion, well, the bond between those oligopeptides, which means that mesh-like structure just can't be formed. You've got these long chains of NAM and NAG, but they don't link together to make something much more solid. So I said to you roughly the role of the cell wall, and I said to you roughly that this is really important in terms of giving solidity. So what I have now as a video, and I promised I would show you bacteria exploding, is bacteria exploding. So this is E. coli. They're about to be given ampicillin, and this is a time lapse over about an hour. So you can see what happens to them. And in the beginning, they're going to start elongating because they're getting ready to divide by binary fission. So they're elongating, they're growing happily to divide. And then once enough amoxicillin is working, they can't produce that peptidoglycan, the cell ruptures and explodes. So watch, I'm going to play it. And if you look, I think this one's the first one to go, but they're elongating, and then poof, like a balloon popping. Some of them, this one over here, expanding in a bizarre way, but it's going to blow up anyway. Nothing can survive amoxicillin. Oh, there it goes. And this is the last one over here. Very satisfying. I'll play it again because it's so satisfying. So you're going to watch them elongating. It's amoxicillin added to susceptible E. coli. Elongate, and they just burst out. It's really mostly mechanical. There's some complex biochemistry to it, but in essence, if you don't have peptidoglycan, you don't have the structural stability you need to prevent the water from flowing in and just bursting your own cells. And that's what it does. So all of the beta-lactams work in this way. Very satisfying. This is essentially how they kill. So obviously then it makes sense that beta-lactams don't work if you don't have a cell wall. So mycoplasma don't have cell walls. So you can't use beta-lactams against mycoplasma. Some cell walls really don't have peptidoglycan, like chlamydia. That's pretty uncommon in bacteria, but it does account for the fact that you can't use penicillins for chlamydia. And then an important limitation is that, and this applies to many antibiotics, but particularly the beta-lactams, is that if a cell is not metabolically trying to divide, it's very difficult to kill by the beta-lactam method. And you can see that why all these cells that you saw in that video were elongating, they were getting ready to divide, so they were building up molecules of peptidoglycan. If they're just sitting there inert, it doesn't matter because you're preventing new peptidoglycan from being formed. You're not destroying the peptidoglycan that does exist already. And so, for example, biofilms are an example of, you can have pretty inert bacteria, and it makes it quite difficult to kill. You do still get some killing, but it's quite substantially attenuated if a bacterium is not dividing. So that's in essence how they kill. Some points in general about pharmacology here that will help us to understand the class as a whole. One is that if you give them orally, there's lots of variation. So some of them work really well. If you give them orally, they get absorbed pretty well. Others really don't, and some of them you just can't give orally, like for example, the classic form of penicillin. Acid destroys it when you swallow it, so it doesn't work well. In general, the penicillins don't tend to be well absorbed. There is at least one or two exceptions, and the big exceptions are amoxicillin, which is pretty well absorbed, about 80% of it's absorbed relative to intravenous dosing. And some of them can't be given at all. Flucloxacillin is somewhere just short of half, so it's not that great. The cephalosporins tend to be a bit better, whereas the carbapenems and the monobactams, they're only available intravenously. So in general, if you had to guess, if you know it's a penicillin, you'd say it's probably not that well absorbed. Whereas if it's a cephalosporin and you know it can be given orally, because not all of them can, then your good guess would be that it's better, and you at least can probably get away with it. I've got numbers on this table to give you some idea. This is bioavailability. So this is effectively saying if I swallow, let's say, a gram of the substance orally versus I give it intravenously, how much of that gram that I swallowed orally, how much of that is absorbed into the system. So for example, penicillin V here, that's the oral form of penicillin, 60%. It's not that great, but not terrible. But you can see the beta-lactams in general don't get well absorbed. You can see the big difference between ampicillin and amoxicillin, otherwise very similar drugs, but the bioavailability is very different. And then augmentin I put in the bottom there because that's a drug we often give orally. It's the clavulanic acids, the rate limiter there, but it's still pretty well absorbed, about 75%. If you look on the right side of that table, you can see some of the cephalosporins. The first, I put in brackets there, the generation. So generations 1 and 2, most of them are pretty well absorbed. So you can give first and second generation cephalosporins pretty comfortably, at least some of them, again, not all of them, but the ones that are oral are pretty well absorbed. Once you start getting to third generation, though, it's hard to find ones that are well absorbed. But again, if you give enough, you can get away with it. So that's an essence of roughly where you're sitting in terms of bioavailability orally between the penicillins and the cephalosporins. Most of them are cleared by renal excretion, and it's often via intact drug. And remember what we said, that people were able to obtain penicillin from people's urine and give it to them again, obviously cleaned it off and dried it off. No, I'm kidding. But you're able to use, because it's intact drug, it's not metabolized drug, you're able to get it back from urine and give it again if you need to in a pinch. And that's what the Allies did in World War II in the beginning when they didn't have enough. And that's, of course, what was done with that unfortunate policeman in the beginning. It's mostly just filtered through, but there are some drugs which are also secreted into the urine actively by the body. But either way, it's almost always renal excretion, and it accounts for the vast majority of the excretion. Hepatic metabolism is much less important. Unlike many drugs, this is quite uncommon actually to be excreted intact in the urine. And there are some clinical applications about this. One is that if you have renal failure, it's going to be important to adjust the dosing of the beta-lactams. And that's, again, if they're excreted predominantly through the urine, clearly if that is impaired, the amount of drug is going to build up pretty fast. And so you almost always need to dose adjust in the face of renal failure when it comes to beta-lactams. Another important implication of that is when you have severely ill people, for example, septic, say very septic people in ICU, say, you can actually get augmented renal clearance because the vasodilatation that occurs can promote excess excretion. So you can actually struggle on the other side with beta-lactams in critically ill people sometimes. And then really importantly, you can often achieve super therapeutic drug levels in the urinary tract with the beta-lactams, provided, of course, the patient's GFR is okay. So as long as they're still filtering enough, you can actually achieve a huge amount of beta-lactam concentration in the urine. That can occasionally be very helpful. I'll give you one example here. This is a 68-year-old female we saw recently who had breast cancer. She had a urinary catheter in situ. She had symptoms of a cystitis and she was febrile. They sent off urine. She has a lot of leukocytes there, 198,000. A lot of bugs. She grew a Klebsiella pneumonia, was more than 100,000 CFUs per mil. Her susceptibility profile didn't look great, though. She was susceptible to most things. She looks like a sort of ESBL there. She required a carbapenem ideally. But she was already empirically on kephterlin. And in fact, the home team had left her by accident on kephterlin by the time we saw her a few days later. And she recovered. So how did she manage to do that? Well, there are probably at least 3 reasons. But just to give you some sort of idea, we know that many UTIs get better anyway. So we can't take all the credit for that. Some of them just are going to get better. We know that before antibiotics, people didn't suffer for UTIs forever. They did eventually get better. Catheter removal in this case really did help. But a third and most interesting reason here is that the ceftazidime MIC, so that's the minimum inhibitory concentration, to give you some idea of how we can apologies to the microbiologists in the audience, but for those of you not microbiologists, give you some sense of the resistance of the bug. So the higher the MIC, the more resistant it is. Think of it that way. So sensitive would be 1 or less. This MIC was 8, so it was solidly resistant, and it was appropriately recorded as resistant, the R, by the micro lab. But have a look at how much you get in your urine. So for example, if you look at the package insert in healthy volunteers, if you give 500 milligrams of kephterlin intravenously, about an hour later, you hit peak concentration in the system, and that's 17 micrograms per mil. And remember, the MIC was, the threshold for susceptibility was 1. So you're comfortably above that level. And of course, it's going to go down as it's excreted and metabolized. So this is give you some idea of, you achieve good levels in the serum. That's fantastic. But have a look how much you get in the urine. At 2 hours, once you've had a chance to filter it through the urine, the urinary concentration is 2,100 micrograms per mil. So massively more than the serum concentration. I mean, you know, this is, you're doing with more than 100, close to 140 times the serum concentration. So you get this a massive amount here. And when you consider that you need time above MIC, and the MIC's threshold would be 1 here, the threshold's 8, this organism is a bit more resistant. But you can see how quite clearly when you're starting with a dose that big, you're still going to have activity in the urinary tract. And that was what happened, we think, at least partly here. Now, I'm clearly not advocating being cavalier about this sort of thing and giving drugs, even though it says resistant. No, clearly not. But just to give you some idea of the fact that you do still retain activity when the concentrations are that high, even in bugs which are recorded as resistant. Beta-lactams tend to be well distributed through tissues. They do well. You don't usually have to worry about whether they get into the lungs or the kidney or the bone. They get into pretty much every tissue. Obviously, the big exception always to worry about is the brain, and that goes for every drug. And there's quite a lot of variation with CNS penetration across the blood-brain barrier. This is standard for every drug, but in general, the beta-lactams get across most tissues pretty well. They sit in the extracellular space mostly. They don't get into cells all that well. So sometimes for organisms such as, say, Legionella, etc., where you really do want an intracellular concentration of the antibiotic to be high, there are better options. But if you don't mind, and most bacteria are extracellular, then the beta-lactams are a good option for pretty much all of them. And then how they kill, of course, is this. These are the classic time above MIC antibiotics. So time-dependent killing. If you look here, if I've given you this hypothetical graph, here's the concentration of the drug as it goes up, time along the bottom axis. So if I give a drug, it's going to go up as I infuse it or as it's absorbed orally. And then the body starts excreting it and metabolizing it, so the concentration falls down, and then I give the next dose. If I link then the MIC, the minimum inhibitory concentration, to some idea of the resistance of the bug to it, then I get this idea, if I plot on the same graph, I get this idea that there's a time above MIC and there's time below the MIC. So here's the time below. Every time that line, the concentration of the graph falls below the MIC, this is not helpful, but the time above MIC is useful. And with beta-lactams, there's a kind of a threshold effect. So for cephalosporins, you want the time above MIC to be about 60%, for penicillins 50, and carbapenem 40. So if you're achieving enough time in the whole dosing cycle above the MIC, then you are going to have maximum killing effect of these antibiotics. It is occasionally quite hard to achieve that time up MIC in really two big areas. One is that if you have unpredictable pharmacokinetics, so if you have an obese patient, a septic patient with very odd fluid status, or very overloaded, for example, depending on the antibiotic, or organisms with high MICs, it makes it difficult to achieve time above MIC. So in general, with beta-lactams, it's best to increase the frequency of the dose rather than the dose itself. Increasing the dose does give you a bit more time above MIC, but remember the body in this sort of excretion excretes a certain percentage. So if you give a higher dose, it just means that more of it's metabolized. So you get back to where you were pretty quickly. So for example, if the half-life is 30 minutes, as it is for, say, penicillin, and you double the dose, you only get one extra half-life, because after 1 half-life, it's back to where you were originally. So you get an extra 30 minutes above MIC. So it's much better in general with beta-lactams to increase the frequency and give a little bit, but more frequent rather than a lot and less frequently. And the extension of this, of course, is extended infusions over 2 to 4 hours, and even continuous infusions. And just to give you the concept, because we've covered this in different talk about pharmacology, but just to give you the concept of this, here's the MIC in green. This is a intermittent dosing. So I give an infusion, I give an infusion, I give an infusion, and you can see it spikes and goes down. But if I just give a constant infusion, you can actually achieve the time above MIC a bit quicker and a bit more reliably in that setting. So we don't do this routinely for beta-lactams, but in an ICU type setting or in people who you worry about the pharmacokinetics, for example, like I said, it's very septic people, very obese people, people with fluid overload states, for example, people at the extremes of weight, this sort of constant infusion, or more commonly just extended infusion, it can achieve your time above MIC slightly more reliably. All right, this deserves its own talk in itself, but just to give you some sense, these are the classic time-dependent killings. What sort of side effects do you get with beta-lactams? The most common we know already, this is the hypersensitivity reactions, by far the most common of any drug allergy. So if you pile all the drug allergies together, you're going to have penicillins and beta-lactams at the top of the pile. We know that when people say, I'm allergic to penicillin, they're about 95% chance that they're wrong. And partly that's because they overcall their own allergies, because, for example, they got an upset stomach or they got a rash that wasn't related and someone linked it to penicillin. But it is possible also, and it's relatively common, that you have a legitimate allergy, but then that resolves over the years that go. So in other words, and we know that after about 10 years, so the resolution rate is about 80%. And so in other words, even if you did legitimately have a reaction, that may have passed by the time someone says, again, I'm allergic to penicillin. If you look at the penicillins, for example, and it is more commonly penicillins, but it can be any beta-lactam, the rate of cross-reaction with other types of beta-lactam is quite low. So here's penicillins, for example. If you look at the cephalosporins, about 2%, you have about a 2% chance of cross-reacting, less than 1% with carbapenems. And aztreonam functionally 0%, although there's an exception to that, which I'll come to a bit later. So you've got some sense here. And again, these numbers vary if you look at studies, but this is probably a good total estimate. So in other words, even if you are allergic to penicillins, if you give a different beta-lactam, your chances of a reaction are pretty low. And that's helpful, especially in the minor reactions. If it's a bit of a skin rash, you could chance, for example, a cephalosporin or carbapenem. Clearly, though, if it's anaphylaxis, though, you wouldn't want to give someone a 2% chance of anaphylaxis with the cephalosporin, and so you'd have to reassess. And Nosisa Sipambo gave a wonderful talk about beta-lactam allergies, and which is on our YouTube channel, which you can look at for further details. I wanted to just give you one, though, helpful way that's come out in the last year. A very useful group of people in Italy looked at this, and it was and to give you a case scenario, say you have a 24-year-old female who says she has urticaria following penicillin. What's her risk of getting urticaria again? And what this group did is they looked at what they call the 1-1-1 criteria for beta-lactam allergies, and this is specific really to urticaria. And the questions are, did the urticaria develop after the first dose, that's the first one, as opposed to the subsequent doses? Did urticaria develop within the first hour of the inciting, dose, I should say? And did the urticaria resolve within 1 day of stopping the beta-lactam? So that's 1-1-1, right? That's where the word comes from. And if they answer yes to all three of those, they had a positive predictive value of 90%. In other words, you really shouldn't be giving this drug again. If you want, you can do desensitization, for example, if you really need it. And the negative predictive value was 80%. So if they say no to at least one of those three, they were 80% likely that they wouldn't get a reaction if you gave them the drug. And that's pretty useful. The area under the curve there was 90%, 0.9. And that's one of the better rule in, rule out tests that we have. And this is new. This came out in 2021. It was published. I've got the link there in the bottom of the page. But this is a pretty useful thing. And again, this applies, we talk about urticaria, but that's the most common form. This is not, for example, applicable to, for example, anaphylaxis, in which case you'd be far more cautious. But that's a useful way, and that's come out fairly recently. Cytopenias are common with beta-lactams. Neutrophils will start dropping occasionally. You can have Coombs positive autoimmune hemolytic anemias, thrombocytopenias. One thing with the cytopenias that I've certainly noticed is that it's often with a prolonged courses. So if you're giving someone 5 days of antibiotics for their pneumonia, it's very unlikely that you're going to see any of these cytopenias. They take time to develop. Whereas if you give someone 4 or 6 weeks, for example, for their endocarditis or their osteomyelitis, it's not uncommon to see these at all. In fact, I'd say probably 20–30% of the time you'll see it. You have to look for it, which is one reason that we do recommend in these chronic antibiotic courses to be measuring things like the full blood count and also kidneys and liver at least once a week. Occasionally you do get eosinophilias as well, especially with the cephalosporins. Platelet dysfunction is not usually clinically significant. All penicillins, and in fact all Betalactams, bind to the ADP receptor in platelets, so they prevent aggregation of platelets. And so you could, in theory, worsen platelet function and therefore get bleeding, but it's pretty rare for that to be clinically significant. Which of the following drugs do you think it would be most likely, though, with? If I tell you it's dose dependent on the beta-lactam, which of those 5 there are you most likely to see it in? Give you just a second to think about it, because you can actually work out the answer. So the answer here is piperacillin tazobactam. Why? Because of all the penicillins, in fact, beta-lactams you get, the dose of piperacillin tazobactam, so tazocin, is enormous relative to the other ones. So for example, if you give, let's say, Pseudomonas doses for pip-tazo, that's 4.5 grams 6 hourly. So that's 18 grams of penicillin in a day. Whereas if you give ampicillin, for example, that dose might be a lot less. For example, if you're giving a community-acquired pneumonia, it might be a gram, TDS, you're giving 3 grams. The pip-tazo, just be careful of it. It's also got a lot of sodium in it for the same reason. They all have sodium, but you get a lot more sodium with that, and you get a lot more platelet dysfunction. So occasionally, for example, if you have other reasons for platelet dysfunction, such as renal failure, and that some people will be strict and say, well, we should steer away from pip-tazo. It can be an issue, but really it's not a clinically relevant issue with any of the others. And you wouldn't expect it to be a clinically relevant issue alone either. It's really in people who've got other risk factors for platelet dysfunction. Seizures are common with, well, at least relatively common with all the beta-lactams. They all bind to GABA to varying degrees in the brain. GABA is an inhibitory neuron, remember, so if you bind to them and inhibit them, you're going to inhibit the inhibitor, which means you lower your seizure threshold. You can get encephalopathies as well, in addition to obvious seizures. And the time to be really careful with beta-lactams is particularly in renal failure. And remember, we said because they're excreted predominantly, almost exclusively in many cases by the kidneys, people with renal failure, you have to be careful of that dosing. If you overdose them, if you give them the normal dose, despite their renal failure, that's really the time when you often see seizures. And that can be a much bigger problem than you would otherwise see. And then acute interstitial nephritis is, again, something that people don't consider, in my experience, often with the beta-lactams, but should. The kind of classic triad there is raised creatinine with a rash and fever, but it's pretty uncommon to have that triad. In fact, only 10% of people have that triad in one big study where they look backwards. So what you'll normally see is just the creatinine that's rising. So you're putting someone on a patient on say a beta-lactam, and after a week or so, you see this creatinine starting to rise, and you don't have another cause for it. Please do consider this. It's not uncommon, but people in my experience don't tend to consider it. More useful is some of the other features. Eosinophilia is about a quarter, so if you see that, it should be a strong consideration. But again, 75% of the time, it's not going to be there. Arthralgia is nearly in half, so that's, again, just a little bit more useful. Someone who's complaining of arthralgias and has a rise in creatinine on a beta-lactam, please do think of this. Some people have eosinophiluria, so eosinophils in the urine, but that's not particularly sensitive or specific, but you can look for it. And the urine is usually pretty helpful. It's got white cells and red cells, and often white cell casts and variable proteinuria. So it's quite an active urinary sediment. So that sort of active urinary sediment plus the rising creatinine in the appropriate patient on a beta-lactam is a good signal to at least consider this. If you consider it early enough, you can stop it and it gets better. Sometimes you use steroids, and they may, but people can go into dialysis requiring renal failure, for example. It can be pretty nasty. It's typically non-oliguric, so they're passing a lot of urine, but their creatinine keeps rising. So please be aware of this in people on beta-lactams whose creatinine worsens, at least as one consideration. In general, with all the side effects, I've just covered the big ones there. The penicillins are probably worse than other ones. And if you look at most case series and most package inserts and most big groups of side effect lists, in general, the penicillins are worse than the cephalosporins and the carbapenems, for example. The penicillins tend to have more hypersensitivity. So you've heard of people saying, I'm penicillin allergic. You don't as nearly as frequently hear, I'm cephalosporin allergic, and that's not just a quirk of society, that is reflective of a reality. Cytopenias tend to be a bit more commonly seen in penicillins, and then interstitial nephritis is more common in penicillins than the cephalosporins and carbapenems. These are class effects, though they do occur across all the beta-lactams, but just to be aware, the penicillins tend to be a little bit worse than the other 2 or 3 classes in terms of these side effects. Okay. So what we're going to do now is just move into the classes themselves and just give you an overview of some of the big kind of take-home messages across them. So this is the penicillin group. The first ones were called natural penicillins, and that's penicillin V, penicillin G. Those are the ones which appropriately come from nature. So these are the ones which were extracted and purified from Penicillium originally. And then what happened with time is that staph pretty quickly developed resistance to it by penicillinase. And so there was a concerted effort to develop penicillins that weren't able to be broken down by staph's penicillinase. So those are named the anti-staphylococcal penicillins, and we'll come to them, but you may know them as cloxacillin, for example. And then on the other side, the gram-negatives again developed resistance pretty quickly as well. And so there was a concerted effort to improve the penicillin's activity against gram-negatives, first by what we call the minor penicillins, which I'll come to in a second, then specifically anti-pseudomonal penicillins, because Pseudomonas is a very difficult bug to kill. And then with time, and very commonly now, we've got these beta-lactam, beta-lactamase inhibitors. So they're actually designed to stop the bacterium from using its beta-lactamase on the antibiotic. Penicillins tend to have pretty short half-lives, so they usually dosed multiple times a day. And you've noticed that if you consider, say, penicillins versus cephalosporins, on average, the penicillin is going to have to be dosed more times a day than the cephalosporin or the carbapenem. They mostly have poor oral absorption, and we covered that in the previous slide. There are a few exceptions to that, though. So the natural penicillins have a very, very short half-life. And if you're looking at, say, PenG, it's measured in minutes. But there are specific long-acting forms such as procaine or benzathine penicillin, which are given intramuscularly, for example, which can be given for longer administration. But we really use this for syphilis, occasionally a few other things. But in general, the fact that you have to dose them so frequently in most conditions means that in almost every other condition for which the bug is penicillin susceptible, you end up using a different treatment. You end up using, say, a cephalosporin or something like that. And that's really just the problem of a half-life that's very, very short. There's still treatment of choice for Treponema pallidum, for syphilis, but for most other things, and there are exceptions, for most other things, though, you're going to find a different drug rather. Then there's the anti-staphylococcal penicillins, and they tend to be pretty poor at gram-negatives, because remember I showed you that diagram where the penicillins really developed in one of two ways, either good for staph or good for gram-negatives, but there's no real penicillin that's good for both of them. So these ones are not great at staph. Sorry, these are good at staph, but not great at gram-negatives. You know them, for example, as cloxacillin, but you may have heard of methicillin, such as methicillin susceptible, or oxacillin. All of these are really the same. Again, they have a pretty short half-life, so they have to be dosed pretty frequently, but they also cause phlebitis not uncommonly. So it's pretty nasty. If you're trying to treat staph, for example, if it's a bad staph aureus, say bacteremia or endocarditis, you often end up needing to dose it officially 6 times a day, which is very difficult in most settings outside of ICU or high care. So then we try and jiggle it a bit and try and give a higher dose 4 times a day, but that's not quite the same, not quite as good. So this is a major downside of these staphylococcal penicillins, at least for severe infections. Less severe infections don't have to be given necessarily quite as frequently. You also get quite a lot of acute interstitial nephritis. So these ones really do cause interstitial nephritis quite a lot, even more than the other penicillins. And they are mostly, this is a bit interesting compared to the other penicillins, mostly metabolized by the liver, so they don't need renal dose adjustments. One of the very few beta-lactams that don't get renally dose adjusted. So if you're on cloxacillin, say for staph aureus, if you end up going into renal failure, you still give the same dose. And that's, again, it's an unusual feature of it compared to most of the beta-lactams. So we use it mostly for MSSA. It does have activity a bit more broadly against some, say, streptococci, but in general, you're going to be using these for staph aureus that's susceptible to methicillin. Again, not a lot of other reason to use it for other conditions. What about the minor penicillin? So this is the other half of that graph or that diagram. So now you're really trying to aim to get better gram-negative coverage. These are better water soluble, so they can actually get through the porins in that outer membrane of the cell wall for gram-negative. So they end up with better gram-negative activity. They tend to have a higher incidence of diarrhea, ironically, than when they're given compared to other penicillins. You can get a rash after EBV infection. This is occasionally quite relevant. So people get, say, a sore throat as a child from EBV infection. A bad GP gives them minor penicillins because even if they don't qualify for it, what happens then is they get a bad rash and they get called penicillin allergic for the rest of their life. They're not truly penicillin allergic because it's really the combination of the EBV and the penicillins that does this. You can give these drugs again and any other penicillin again at any other time and you won't get that rash. Important to be aware of it though. Ampicillin and amoxicillin are the two in this class, the minor penicillins, and you can see they start with am, as in for amino, which is where the name comes from. They're pretty much the same except for the oral manifestation. So ampicillin, you can give it orally, but it's pretty poorly absorbed and cause a lot of diarrhea. And so we pretty much, if you ask for an oral amino penicillin, you're going to use amoxicillin, but intravenously you could use either. We usually use ampicillin in our country, although both are fine. Europe, I think, uses a lot of amoxicillin intravenously. And then where do they sit now? Well, we can use them for respiratory tract infections, although the Betalactamase production from Haemophilus does limit that to some degree. We use it still as pride of place for enterococci. So enterococci really do seem pretty susceptible to this drug, and we use it really as predominant. So if it's susceptible to amino penicillin, that's the drug you're going to get. What about anti-pseudomonal penicillin? So Pseudomonas is always a trouble bug because it's got many different ways of being resistant. As it turns out, piperacillin works against Pseudomonas, ticagrelin works against Pseudomonas, but as it turns out, all of them are available only in combination with a beta-lactamase inhibitor. But in fact, we don't use that beta-lactamase inhibitor for the penicillin, for the Pseudomonas effect. So if we're giving piperacillin, tazobactam, it's the piperacillin that we really want. Tazobactam, though, does extend activity against other gram negatives and other gram positives. So it makes it a pretty broad spectrum antibiotic when you combine the two of them together. So it's going to be used well for Pseudomonas, but it's a pretty broad spectrum drug, as we know, for many other things. It does work well against enterococci as well, which is useful to know as well if you need tazocin for some other reasons. And then, so we've covered the Pseudomonas parts, we've covered the amino penicillins, we've covered the anti-staph penicillins. And then the last big part to mention about penicillins is these beta-lactamase inhibitors. The top three you may be familiar with, certainly clavulanic acid and tazobactam, because we just mentioned piperacillin, tazobactam. Sulbactam is a pretty old one. We don't have much of it in this country, but they use it a lot overseas and many other countries. Really pretty similar to clavulanic acid. And then on the bottom three here, these avibactam, vabobactam, and relebactam are some of the new ones, which you may be familiar with from some of the names, but really are storming the market at the moment. They only work against some beta-lactamases, and they vary. These bottom three are much broader than the top three, for example. And they really aim here to restore activity. So they don't of themselves have any clinically useful effect at killing bugs. What they do there is they really prevent the bacterium's own beta-lactamase from hydrolyzing the parent drugs. In other words, if you're using piperacillin tazobactam, the tazobactam shields the piperacillin from beta-lactamases that the bacteria produce that would otherwise hydrolyze the piperacillin. So they just restore piperacillin's activity to its full potential, but they don't add activity to it. One exception, sulbactam, which actually does have some activity against Acinetobacter. They're very useful for anaerobes. So many anaerobes have a beta-lactamase. So if you have any sort of beta-lactamase inhibitor as part of the drug cocktail, you don't need to add specific anaerobic cover because they work. The older three are on the side there. You can see from that molecular structure, because now you prosed it, that it is a beta-lactam itself. So these beta-lactamase inhibitors on the clavulanic acid, sulbactam, and tazobactam are actually beta-lactams, although they don't have much clinically useful activity, and they do what's called suicide inhibition. So they bind to the bacteria's beta-lactamase, and they prevent it, and it's irreversible binding, and they prevent it from working. Whereas on the right, there's some of the new ones, avibactam, vabobactam, and relebactam. You can see from that molecular image at the bottom, that's avibactam. It's not a beta-lactam. You don't see that nice square with the nitrogen as part of it. It's related, but they're not strictly beta-lactams. And they're not irreversible inhibitors. They're actually reversible, but they bind to the beta-lactamase and prevent it from working. All right, so those are the beta-lactamase inhibitors. And they do a lot of good work. If you look, for example, here at staph aureus, which is normally susceptible, if you look at amoxicillin, almost never susceptible because the staph aureus has a penicillinase which hydrolyzes, and the MIC is very high, 16. Whereas if you add clavulanate to it, it gets it all the way down to 1. So this is as if you'd given amoxicillin back in the 1920s when staph wasn't full of penicillinase. And you've restored it. You've taken us back 90 years to full effect of amoxicillin. But, and if you look, for example, MRSA, it doesn't make a difference. And that's the reason is because it's not the same enzyme. It's not a beta-lactamase that drives MRSA resistance. It's actually changed to the penicillin binding protein. E. coli, again, you could restore activity. Haemophilus similarly, and Pseudomonas not, because again, it's non-enzymatic. So Again, this is really showing you with amoxicillin and piperacillin that if you add a beta-lactamase inhibitor, if the mechanism of resistance is a beta-lactamase, which that drug can get around, you can restore activity. It's worth just pointing out MSSA there, that's augmentin and tazocin. If you look at those two options there, you can see that those are pretty good staph options, actually. Whereas the parent molecule gets hydrolyzed by staph, once you start having the beta-lactamase inhibitor, you get pretty good activity. And again, not first choice for staph, but you don't, for example, need dedicated staph treatment if you've got augmentin on board or piperacillin and tazobactam on board for in the vast majority of cases, because in fact, they're pretty good staph agents because the beta-lactamase inhibitor has taken us back 90 years to a time before staph was able really to hydrolyze the penicillins. The only the only beta-lactamase inhibitor we have in South Africa is clavulanate. It's not, you never see more than 125 milligrams of it. And the reason is you get far too much diarrhea. So if you give, say, 375 augmentin, you get 125 milligrams. And as you go up with the augmentin, in fact, the amoxil dose goes up, but the clavulanate doesn't. And you really can't avoid that because of the amount of diarrhea you get orally. So it's a limit on the amount that you can actually get. What about cephalosporins? Well, this happy graph between first, second, and third generation was all proceeding according to plan, and then they messed up with fourth and fifth generation, which messes it all up. But in general, cephalosporins from the first to the third generation go from being predominantly gram-positive activity to having predominantly gram-negative activity. When it hit fourth generation, though, they hit the jackpot, and they managed to find a cephalosporin which is very good at gram-positives and gram-negatives. And then fifth generation, sometimes not even, it's just known as an anti-MRSA cephalosporin. Don't even give it a fifth generation name. Its really aim there is to get to cover MRSA. So it's the only beta-lactam of all this which can work against MRSA, methicillin-resistant staph aureus. And its gram-negative coverage is actually, it's not bad, but it's a bit less than cefepime. And so that's really the story of the cephalosporins from first to fifth generation. They don't, on the whole, there are some exceptions, but they don't tend to have very good anaerobic activity. So if you're using a cephalosporin, you usually need to add anaerobic cover if you want to cover anaerobes, for example, if you had an infection of the gastrointestinal tract. The first generation ones are pretty much used for MSSA and surgical prophylaxis, because again, you're trying to prevent staph infections. They're very good for gram-positives. They don't have much gram-negative activity. Some of them they do, but not a lot. And so you're really using them for staph aureus, and they can be used as an alternative for staph aureus. So they have less phlebitis and they have a longer half-life, so you can infuse it less frequently. So I actually prefer them, seeing as there's no great evidence that say kephterlin is any worse or better than cloxacillin. I actually prefer this in most cases because, again, you have less phlebitis and you can dose it correctly in the state sector. It doesn't allegedly cross the blood-brain barrier as well. So if you are treating staph and you have, say, a brain abscess, you might want to stay away from this and rather use cloxacillin. Although I just leave this up there, that there is actually a good case to be made that that's unfounded. It seems like this idea that it doesn't cross the blood-brain barrier well really derives from a different first-generation cephalosporin named cephalosporin. And that didn't get across the blood-brain barrier well and gave all of the other cephalosporins a bad name in the first generation. So in fact, if you look at it, there isn't a lot of good evidence to suggest it's any worse than cloxacillin, but you'll still see it in books. And it's still not going to be first choice in the CNS infections for that reason. I'm going to skip second generation cephalosporins because it's really much more important to talk about the third generation cephalosporins here. Ceftazidime of them, and you can see them on the right. There's ceftazidime, ceftriaxone, cefotaxime. Ceftazidime is a bit of an outlier. It's got pseudomonas activity, but it really doesn't do much for gram-positives at all. Whereas the other ones have a pretty good gram-positive spectrum. So ceftriaxone, cefotaxime, and ceftazidime all cross the blood-brain barrier well. So they're very useful for CNS infections, and that's pretty useful for the cephalosporins. Obviously, ceftazidime, though, doesn't have gram-positive activity, so you wouldn't use it empirically. You'd only use it if you had a known gram-negative that was causing CNS infections. They're notorious for inducing resistance among gram-negatives. And so this is one reason why the empiric use is discouraged often in many settings, say, for example, pneumonias. Ceftriaxone is worth just talking a bit on its own because it's a little bit different to others. It's once a day for all indications, but not meningitis. The dosing you're going to use in meningitis is always going to be twice a day and higher dose. It can't be used in neonates, so cefotaxime is better there, both because it interacts with calcium-forming crystals and because it can lead to biliary sludging, which causes hyperbilirubinemia, which in neonates can cause kernicterus. And it does have MSSA activity, so you could use it, but the MIC is generally higher, so you have to use quite a lot higher dosing to get the same dose. So it's not going to be first line for staph, but occasionally, especially for the less severe staph infections, it may be tolerable. Say you've got a skin and soft tissue infection, for example, which is not life-threatening. And if you're otherwise using kephterlin for another reason, that may be sufficient. Otherwise, you need to up the dose. It's not just neonates, though. So this is a case which we did see a couple of years ago. This is an 89-year-old woman. She came in with pneumonia. She's put on kephterlin. Day 7, she develops right upper quadrant pain. And they do an ultrasound and they see gallstones. But interestingly, she had an ultrasound when she came through the door in the emergency department. And that ultrasound did not show gallstones. So she's had, if you like, acute gallstone formation. So what's the diagnosis there? I'll just give you a second to think about it. And the answer really reflects what we mentioned on the previous slide. It's actually what's known as this biliary pseudolithiasis. It's kephterlin, which in people, especially, so it's not just the neonates, it can be people with other biliary issues or occasionally just old age. And you can get crystallization of kephterlin with calcium, and that forms these stones. And it actually, if you pick it up and you make the diagnosis and you stop kephterlin, it usually reverses within a week. And these stones disappear again with time. Certainly the symptoms resolve pretty quickly if you stop it. So it's worth just thinking about. People don't often consider this is not common, but it is a known side effect of kephterlin specifically. And then 4th generation, we know it's got Pseudomonas activity. It's got good gram positives, good gram negatives. So it's the wonder drug, except that it's just too broad, gets across the blood-brain barrier too. And one of the issues is that, again, it's just too broad, so we don't use it for empiric community-acquired infections. But it's not bad for nosocomial infections, not bad if your back's against the wall in other ways. One interesting thing about it is it does cause a lot more neurotoxicity than other Betalactams, again, especially when people have renal failure. But you get this weird sort of stunned look with kephterlin. It's in kephopeme and cephalopathy. And that's an important issue to know about the 4th generation. Again, the 4th generation is just kephopeme. And the 5th generation is just kephterlin, which is the only Betalactam which works against MRSA. It's a spectrum apart from that is roughly kephterlin plus MRSA. So it works, it's no more broad than kephterlin for the gram negatives and gram positives, other than the fact that it adds MRSA coverage to it. It's not a huge amount of use because, again, it's struggled to find pride of place for MRSA because you've got so many other options which have better evidence-based and longer evidence-based. But it's pretty well tolerated and a good option. It does work a little bit against Ephicalis too, but it's seldom used as therapy of choice for that. So that's there. And then just really briefly, the carbapenems, because there's not a lot to say to add to what we've already covered. The only thing to understand with the carbapenems is that you really need to divide them into urtopenum and the other carbapenems because they're quite different. So for urtopenum, again, by the way, they work well against anaerobes again. So again, you don't need anaerobic cover if you're using a carbapenem. So for urtopenum, it's once daily dosing, and it's narrow spectrum activity. It doesn't work against a few of the other bugs that the other cephalosporins work at. The most notable of these are Pseudomonas and Acinetobacter. So it's got a slightly narrow spectrum activity, and it's given once a day. It's a pretty good drug, except that, again, it's the narrow spectrum of activity. And then the other cephalosporins really have a very broad spectrum of activity. I just want to pull out imipenem specifically because it's, again, a little bit different. One is that you will have seen it's called imipenem silostatin. And the reason it's called silostatin is because, in fact, imipenem can be metabolized to a nephrotoxic product and is so when you give it. So silostatin blocks that reaction. So whenever you see imipenem, it's actually imipenem silostatin. So if you're ever wondering what that is, it's just to prevent the toxic metabolite from forming. The other thing is that it does give more seizures compared to the other carbapenems. So again, be careful in people with other CNS issues like meningitis or in people with renal dysfunction, because remember, again, we said beta-lactams, whenever there's renal dysfunction, most of them, the levels increase quite a lot. Because I just pulled out that meropenem and doropenem don't need specific mention. They're very broad spectrum antibiotics, which we use a lot. And then lastly, aztreonam. This is one that many people don't know much about. I have a soft spot for it. I used it a bit previously. And it's a useful drug in the right setting. It's the only of the monobactams, because remember, that's the 4th group of Betalactams, monobactams. It's only got activity against gram negatives, unusually for Betalactams. And it includes Pseudomonas, so you can use against Pseudomonas. So if you're worried, or if you're trying to remember its spectrum of activity, it's pretty much ceftazidime. And in fact, that's a good way of thinking about it for another reason too. One is that and we'll come to this in terms of the hypersensitivities, it's got a very low incidence of hypersensitivity. So you can use this, if you're penicillin allergic to any of the other ones, you can use this drug with happiness, because in fact, it's structurally very different. Still a beta-lactam, but it's structurally different enough that you don't tend to get this allergy. The one exception to this is ceftazidime. Remember I said, think of it like ceftazidime. And that's because the side chain is actually identical. So if you're allergic to ceftazidime, it might be that allergy is driven by the side chain, in which case you should avoid aztreonam as well. But that's the only time. Otherwise, unless you get that history, you're welcome to use aztreonam, even if you've got a pretty bad beta-lactam allergy from the other side. And then you can actually use this one by inhalation as well for people, say, with cystic fibrosis, to prevent exacerbation. So it's pretty good. If someone's coming with a penicillin allergy and you want to cover gram negatives, this is a good option. It's given relatively infrequently. It's well tolerated. Don't get the allergies with it, but it only covers gram negatives. You need something else for gram positives if you need to cover them. All right. So that's more or less the overview. So let's go through what we've learned, and then we'll answer questions. If you have any questions, please type them in the box as we go. You now know what a beta-lactam is, and we've shown you there the carbonyl group and the amide, and then a cyclic amide is a lactam, and a 4-ring cyclic amide is a beta-lactam. So now you roughly know what that is, and that's absolutely pointless otherwise to know your friends with. You know how they work, and we've described how beta-lactams have inhibit effectively, or they bind to penicillin binding protein, which is a fortunate name for a substance which otherwise cross-links these NAM and NAG residues on the peptidoglycan, so that prevents effectively formation of peptidoglycan, which therefore prevents formation of the cell wall of membrane of bacteria. And we know what happens when that doesn't occur. You know most of their side effects, and we know that they're pretty shared. So if you're worried about beta-lactams, yes, different agents have slightly more or slightly less of some of them. Occasionally you do get a unique side effect, but they're pretty common. You know that you get hypersensitivities to all of them. You know you can get renal issues, acute interstitial nephritis with almost all of them. Seizures, cytopenias are the big ones. So these are again shared. So if you know this in general, you know a bit about beta-lactams in general. Particularly, you need to pay attention to dosing in people with renal dysfunction. And that's again because most of them are excreted predominantly by the kidney. So if you have renal failure and you're not excreting them, they build up pretty quickly. You know that the big 4 groups are penicillins, cephalosporins, carbapenems, and this odd group called monobactams, which only has one member that we clinically use called aztreonam. And you now know not to forget aztreonam because I have a soft spot for the drug. You know how beta-lactamase inhibitors work, so they prevent the bacterial enzymes from hydrolyzing the beta-lactams. You know where some of the individual beta-lactams fit in. We've covered the penicillins and given you an overview of some of them, and the cephalosporins and the carbapenems as well, in addition to aztreonam. You know that fungi hate bacteria, very important and good to know who your enemies are. And we often turn to fungi, not just for penicillins, but for other molecules as well in their roughly 90 years since penicillin was discovered. And fungi are very, very good and have a long history of killing bacteria, and they're pretty good to reference. And you know that roses can kill you. Most importantly, don't go and garden, at least in the pre-antibiotic era. This poor gentleman whose face, unfortunately, gets attached to penicillin for all of history. And then just because it's cool, while I have a look at the chat, you know what happens when you give beta-lactams, and these bacteria explode, which is awesome. And I'm going to show it one last time, and then we'll pause for questions. There they go. Good to know what's happening inside your body. All right, this again is E. coli with ampicillin given. All right, I'm going to stop it there. Thank you very, very much. I hope that's given an overview. It wasn't too much and also too little. And I'm very happy. I'm going to stop sharing and I'm going to look at the chat now and take some questions. All right. John's mentioned the mold in Dr. Fleury's coat. Wonderful. Yes, I didn't go into it, John, about the penicillin story. So there's a lot of controversy over the relative amounts that people contributed. I think Fleury got the Nobel Prize along with, if I'm not mistaken, along with Alexander Fleming and someone else. But Alexander Fleming, after discovering this and kind of showing the point, didn't contribute a lot to the mass production. After that, he more or less left alone. He shipped his samples across, but it took more than a decade for people to get good at producing any significant amount of it, and he was not involved in that part. So that sounds like a really exciting book to look at. Nadia is saying we're having a really hard time getting penicillin G for treating congenital syphilis. Has a drug like ampicillin been studied for use in this disease? So people have looked. Unfortunately, there's not a lot of good randomized trial evidence in syphilis, neurosyphilis. Traditionally, penicillin is thought to be the best, penicillin G, so if it's helpful if you reserve stock for them. So we, for example, in our hospital don't allow penicillin G actually to be used for anything other than neurosyphilis. I will say one thing though, and that's that the evidence for it saying being worse than cephalosporins, particularly something like, so I wouldn't use necessarily ampicillin, but you could use kephterlin, although you mentioned congenital syphilis, so that does limit your options. You can't use kephterlin for that. So one of the pediatricians can perhaps chip in. I'm not familiar with peds, but in adults we'd use kephterlin. And when people do propensity matching and try and look as well as they can between kephterlin and penicillin in terms of outcomes, trying to control for all the variables, actually kephterlin ends up better in at least the big regression analyses. So I think it's still to be determined, although all the textbooks are going to say penicillin G for first line. Perhaps one of the pediatricians can chip in for alternatives for the neonatal period. Then there's a question, in my setting, do I find that there's a hesitance to use cephterlin alone for MSSA CNS infections? I think there is a hesitancy, and I think it's a good hesitancy because we know it's not as good. The MICs tend to be 1 to 2-fold higher for cephterlin, and if you're already trying to get across the blood-brain barrier, you know you're going to lose a lot of it in that period. So I wouldn't use it, to be honest. I do think, backs against the wall you could, but I do think you could use, say, cloxacillin or other agents. If you are forced to do it, cephterlin's okay. You're going to have to follow it up relatively closely. It does work against MSSA. We know that. The question is just really how good is it? And if you up the dose to 2 grams BD, that's enough for staph in most settings. But I would worry about the CNS component. People have used that dose and successfully treated staph aureus abscesses, though. So I think it would just be something, if you have to use, just to follow up closely.